my biggest thing about questions are always, it's not where you're getting the questions, it's doing more questions, getting more familiar with questions, how to do them. But you'll find that it's the same over and over again whenever you are doing them. And it's like I said, it's more questions that you're doing, the better off that you are. All right. So, and that's kind of what we're going to talk about today. All right. So let's get into the question sets. And like I said, I'll record this so the other class can see it. So, like I said before, in class, a lot of times people focus so much on writing down questions. And I'm getting the same questions from the same places you're getting them. So it's never like that, you know what I mean? So just focus on the process. All right, let's get into it. All right, so first question, and you can work on your own, and let's go. All right, so let's look at it. So I'm only giving you 30 seconds because I don't think we need a whole minute because I'm going to talk about it, right? So it's just going to take too much time. All right, so nurse is admitting. All right, so that's the first case. So it's now, and this is what's going on. Client's diagnosed, okay, with acute exacerbation of end-stage COPD. So the first question is what kind, right? Emphysema, bronchitis. It doesn't say, so therefore I always pick, episodic, right? Because emphysema is generally going to have end stage, hovering low 90s, which we talked about. But patients with emphysema tend not to be emergently admitted, right? So where bronchitis tends to have dyspnea, dusky color, it's an airway problem. And what we talked about in class where we said that the bronchioles are actually having problems, right? All right, so next thing though is dusky color, in case I didn't see that there was a problem. You have dyspneic too, in case you didn't see there's a problem. And in case you didn't see there's a problem, 36 respirations, okay? So this patient is in distress. All right, in there, I'm admitting them in distress. Okay, so what do you implement first? Okay, so first, what is going to address? What's going to change? What am I going to do first, right? So what's going to change this patient first? So, all right, so now the first thing is that, okay, apply O2 at 10 liters. Wow, that's awful high, right? It's incorrect because you can't go 10 liters, right? So this is a content-based question, whether or not you got this information. Liter nasal cannula. You never put a nasal cannula at 10 liters, right? You could see 5 liters, but that's pushing it. So that's an incorrect statement, so I'll remove that right away. Okay. So if I was to change a question like this, I would say, what's the priority action? Okay. And so now you have priority action. So then you would say, okay, well, that's an implementation. Implementation, that's an assessment, and then that's an implementation. And the principle is that you assess if you need the data, but there's enough data in this question. So, is the patient in distress? Yes, they're in distress. So therefore, I'm not going to assess. All right. So if this change, so like I said, if I'm crafting a question or NCLEX is looking at this, they'll remove something like this and add a priority action. Okay. And so it's the same question as what you'd see on a test, but it's just formatted differently. That's why every question that you do is valuable. It's just recognizing how it's written. All right, so the next thing is assist the client into the high Fowler's position. Well, that's an implementation, and that seems okay. Could that change the patient? Well, what position are they in now? Well, I'm admitting them, and I have them, but is that the standard? That, they're automatically, no, I have the opportunity to change this position. So yes, I'm going to keep this. So if I keep it, I move on to the next one. Monitor the client's telemetry reading. What the hell's that, right? Okay, so here I have a patient who's having all these problems. They're in distress, and I'm like, you know, so it's not. I'm not going to look at a monitor. It doesn't make any sense. So let's get rid of that. And now, if I could do anything in the room, what could I do? And I would do this before I do this, right? So, and that's the first principle. All right. So the next question.
Kevin?
Yes.
If you can go first, Gabrielle.
No, you can go.
All right. If it had said which intervention is best, would 4 be the answer?
Yeah. So the best intervention is get somebody else involved, right? So like I said before, questions are not always answered that way. It's usually when you're in between two, right? Well, they're not asked that way. That's that best versus first. And yeah, that's a good point because you kind of picked that up from yesterday. The best action is to call the doctor, get somebody involved, not put them high followers. The first action is to do that, put them up high followers. That's a good
point. We assume they're not in high followers because it says is admitting.
Yes, yeah. Okay. And then the principle is that we're not in it, right? Okay, so the reason we're not in it, it's different than a myocardial infarction, right? So myocardial infarction, if you've given nitro, you're in it. It's already happening, okay? So for example, is that, let's put this question with an ABG, okay? So if you drew an ABG, do you have the pulse ox? Yeah, most likely I have it because I'm not just gonna bypass a pulse ox and say ABG automatically. I'll get my vitals first, figure out what's going on. So the assumption is that if there's an ABG there, I'm past vital signs. Okay, because that's a secondary assessment, right? And we said that it doesn't mean that this patient wouldn't get an ABG, right? Because in distress, we're going to evaluate that. But it's the same sort of thing, about a step. But the patient's being admitted, so therefore it is an option, so do that first. All right, anything else? Who else said something?
No, he asked my exact question about best versus first in this scenario, so.
And I try not to talk too much about it because it kind of starts to confuse you when you start looking at questions. But when you start to get those questions out there wrong, it might be because of that principle, right? So where I'm always like, don't call the doctor, you know what I mean? And then do something in the room, and then always look at that. If you get it wrong, you know, say, was that a best or first one? And sometimes they're writing them that way. All right, next question. All right, so let's talk about it. All right, so nurse is caring. All right, so I'm caring for a patient who's diagnosed with COPD. My first question is what kind, right? So I don't know which kind, is it emphysema or is it bronchitis? All right, so I have free liberty to go to both ways. All right, so now which assessment data requires the nurse to intervene for something that is unexpected of this patient? Okay. Use of accessory muscles during inspiration. Well, that's expected of an emphysema patient, and that's why they get the barrel chest and all those types of things. So I would expect that patient because I don't know what's going on. Now the distractor of that is a lot of times you see accessory muscles and you automatically think peds. And it's kind of drilled in your head about accessory muscles and peds and pediatrics. So you always think, okay, that's an acute distress. Because accessory muscles and retractions in peds, it's always acute. It's not a chronic finding. But once they start to use the accessory muscles during inspirations, you see what's happening here is that's why they're expanding their lungs and they're getting that barrel chest. That's what's happening. And they're basically building up their structure and the mobility of who they are, and they're changing. All right. So a lot of times that's why people will generally pick a question like that because of the peds thing. All right. So oxygen flow meter is set at 3 liters while the client is ambulating. Would I intervene with that? No, it seems okay. I don't have a problem with that. So I get rid of that one. So if I wasn't sure on this first one, I would hold it. Okay? Because I'm not sure. Just don't pick it, hold it. Next one, presence of, don't care, right? So get rid of that. So now I'm down to 2. I got 1 in rust-colored sputum in a sputum collection container. Okay, well, that's weird, right? So I don't know what that means, right? So do they have a container next door that it's spitting into or something like that, right? So now think about this. You're caring for a client with diagnosed with COPD, right? And which assessment data that I'm seeing requires the nurse to intervene? All right, well, I have use of accessory muscles only during inspiration. Well, that's kind of weird. It's only during inspiration. And then I have rust colored. Well, that's an unexpected finding. I don't expect them to have rust colored sputum. So that's going to require me some sort of intervention to assess what's going on. This patient probably has bronchitis, and now they have pneumonia. And that's kind of what's happened. It's the indicator that the complication of this is pneumonia. And that's what it is. Was that true about number 1, how you kind of think about it? You see it and automatically you're like, that's it. That's got to be the thing, you know? And if you didn't, good for you. I mean, it's just one of those things that I think that's the sight readers. Sight readers will see accessory muscles and they think, that's acute. And that's sight reading. And then you think, oh, well, rust-colored sputum. Well, that's also acute. Rust-colored sputum is characteristic of pneumonia. All right, any questions? Nope, moving on.
Mm-hmm.
All right, so stable patients, stable outcomes within the capacity of no assessments, no admissions, no discharges. They don't do the admission vital signs. They take care of tasks that they can be trained to do. They can reinforce teaching that a nurse has already taught. All right, so let's talk about it. Instruct the UAP. Okay, so the nurse and the unlicensed assistant personnel, UAP, care for clients on a medical unit. Okay, which nursing tasks should the nurse delegate? Okay, what's a stable thing that they can do? All right, instruct the client to increase oxygen level. All right, well, what does that mean? That's vague. And we don't delegate vague things, right? So, 1, we know they don't increase oxygen, okay? So the principle, though, is this is still a crafted question. And what I mean by that is recognize what it's saying. Where this is the obvious thing is, right? Increase oxygen level. But you can remove that and add something else that is unmeasurable, that's vague, right? So I could say something like instruct the UAP to get the patient admitted with dehydration out of the bed. Where you would think, okay, well, they could get a person out of the bed. I'm a PCT. I can get people out of the bed. What's the big deal? Well, they're dehydrated, risk for fall, therefore unexpected outcome. Okay, or instruct the UAP to feed a stroke patient. Got it? Same sort of thing. You as the nurse has to say, wait a second, strokes are all different. Some people have swallowing problems. Some people have weakness problems. Some people, so that's an unexpected patient. And so that requires the nurse to stop, reflect, assess, then delegate. So next thing, document the amount of color consistency of the sputum collection chamber. Okay, well, that doesn't seem like that's long. So I'm going to keep it. All right. So I'm going to keep that one. Bag the specimen in plastic. Take it. Okay, that's keep that. And then refer the client to it now. Right. They don't do that. Okay, so now I'm down to 2. Right. So they both seem okay. Right. So now you say to yourself, which one would require more assessment? Okay. And the first question is, document the amount of color and consistency of sputum. Okay, so now I start to think to myself, okay, well, what if I had a patient who had green sputum before and now have rust? Or what if I had a patient who had clear sputum before and now has green? Right? Am I going to sit on that? Am I going to want to know that? And I would want to know that right away. And I wouldn't want, even though it's within the scope of what they could do, it doesn't bypass this one. Okay, this is more stable. This requires less assessment, and it's more within the scope of the UAP. Any questions about that? All right, is this helpful?
Yes.
Yeah. All right, so moving on. Let's.
I don't know if the vaccine is yearly. I think it is.
Okay, all right. That's a great question, actually.
Whatever.
You know, as far as like, is it yearly? Does anybody know that? Somebody Google it, figure it out. I think it is.
I feel like it's not.
Okay.
Although I'm not.
Well, somebody's got a phone, pretty sure, right now open. So, I mean, somebody can Google it. How often is pneumonia vaccine? All right, let's get into it. So, statement made by the client diagnosed COPD, what kind, again, indicates clinic nurse that teaching's been
Every 5 years.
5 years. Well, that's good to know, right? So, okay,
An annual flu shot is indicated. So, yeah.
P pentagram, 5 sides. 5 years. All right. That's all I'll remember now. All right. So teaching's been effective. So looking for something correct. All right. Well, the first question was, well, now we know this, right? So 1, 2, 3, 5. 5 years. You get the flu shot. That's correct. Yes. Okay. So I'm not sure. True. I must reduce how many cigarettes I smoke a day. Is that effective? Reduce. Okay. How many smoking now? I don't know. 32. All right. Well, I'm going to go to 31. That should be helpful. Well, no. I mean, that's not really going to be too effective, right? I mean, you should stop smoking altogether. So let's get rid of that. I'll make an appointment to see an endocrinologist. What? Get rid of that. Okay. And then so that's it. And this is the follow-up questions. I mean, you know, like I didn't remember what it was for a pneumonia shot. You know, I thought it was 3 years, but anyways, but I wasn't sure, you know, right off the top, and that's why 4 squares, and you start to look at questions. You're like, I don't know that. Now we know. We kind of talked about it. All right.
It's not annually.
It's not annual. So that's perfect, right? I mean, the walkaway's there, right? So as far as remembering. All right, next question. All right, this is a great question. I'll talk about it. All right, so This is the weirdness of what I was talking about, the end stage, that 91%, that 92%, okay? It's kind of a iffy question. I don't think it's a solid question, but let's just put that out there. But let's talk about it. So client's diagnosed, all right? So the first question with end stage. Well, it's end stage right there. So that's a little bit different than diagnosed with COPD, okay? And also the patient is, where's the patient? The patient's not presenting anywhere. So this is a concept question, right? Because there is no location, okay? So no local, right? No location. I'm not in the ED. I'm not on the floor. I'm not caring for or anything, right? It's kind of client's diagnosed, has pulse ox. Which intervention should the nurse implement? All right. So there's nothing, no data there really, other than COPD, oxygenation, period. All right. So document the findings in the client chat. Well, that's a do nothing, but let's see what the other ones say. Okay. Request a stat arterial blood gas. All right. Well, what's the patient look like? Right? Just do I always do a stat? Do I do stat information based on vague data?
No.
No. That's like saying remove this and prepare for intubation. I mean, it's the same thing. It's stat, it's acute, but we never do acute things on vague things. We need more data, right? So to do something, an intervention that's so acute, you don't just do it on one pulse ox. So, same question. Patient's diagnosed with a myocardial infarction and shows VTAC on the monitor. Which intervention should the nurse implement? All right, document findings. Assess blood pressure. Notify doctor. Defibrillate patient. Okay, so here's the data. Here's the setup. Diagnose, MI, VTAC. What are you going to do? Same sort of thing. Okay, so diagnose end stage COPD. Well, that end stage is there for a reason. It's a content-based question based on 91%. And then you know this. Everybody knows that emphysema patient can hover at that range. So notify we don't do any of that, right? We never, here's the problem, nurse, what are you going to do? I'm going to call the respiratory therapist. No, don't do that. And then encourage the client to cough and deep breathe. Okay, it doesn't seem like a problem per se, but I would need more data. Like, would I have a emphysema patient do that? Not necessarily. I might have a bronchitis patient. See, so it has to kind of fall into both camps, right? Which one we're talking about. So this is a straight up content-based question. It's based on, do you know this concept of a low oxygenation is with emphysema, and to document. I generally would never like put a question like this on an exam because I don't think NCLEX would either, because the principle is that they don't want you to kind of do nothing. This is a classic, what I call Saunders question. It's a content-based comprehension, and that's what they're focusing on. That's why when you're doing a battery of questions, sometimes you have these comprehension questions that kind of look like a cute question, right? Because they're wording it the way they're wording it. So they kind of force you into it, but it's just a content base. All right, next question. All right, good. So let's talk about it. So nurse is caring for a client diagnosed with reactive airway disease. So like it can be asthma, bronchitis, because they're reactive, right? Two problems that environmental. Right, it's prescribed montelukast, right, singular, right? So leukotriene thank you for telling me that. Leukotriene which NCLEX will never do. They're not going to tell you what it is too, right? They're not going to give you this. It's going to be just straight this, right? Which information should the nurse teach the client? All right, so looking for something most correct. Instruct the client to take singular when there's a tightening of chest. Well, that's an acute situation, and this is a chronic med, right? So everybody knows that it's a chronic med, so that doesn't match together, so get rid of that one. Tell the client it will take up to 2 weeks for the medication. I'm not sure about that, so I'm going to keep it, okay? Explain that a fast-acting medication is needed for asthma attacks. Okay, I'm going to keep that too, okay? Recommend the client take breathing medications three times a day with, no, that doesn't make sense. Okay, so I'm down to 2, right? So, all right, I'm not sure about this one, okay? But it's singular. And explain the fast-acting, now I'm gonna look for what's more correct. What's most correct out of both of these? Something that I don't know. And then I would ask myself, does everybody know this, right? But does everybody know this? Okay, and everybody knows this here, and that's the credited answer. And sometimes that's what it's about. Because the thing is that, remember, you're studying these medications. So you know what's acute, what's not acute, and different things like that. So if you're studying them, and suddenly you're like, does everybody, did I miss this part? And different things like that. No, you didn't. It's not important to know. Actually, it takes, I think, a day or so. You would not take something for that's going to take 2 weeks, because that would require a level of some sort that it's taking so long to work, like theophylline, those type of things. But this is most correct. Any questions on that? All right, and that's kind of how a question like a chronic medication shows up. It's usually, like I said, chronic medications are always about Maslow and higher level education, teaching, and that type of stuff, and not so much about acute interventions. All right, next question. All right, good. So some good things about this question is there's a lot of data in it, right? So client presents, all right? So that's the first key. They're giving you a situation in the ED. So it's acute. So right away, the location's important because I'm somewhere where acute things are going on, right? So acute question, presents as acute, ED is acute, diagnosed status asthmaticus, if you didn't know, is acute. And then which intervention should you implement first? What's acute? What's going to change patient? Okay. All right, so administer Salumedrol. Thank you for telling me this, the glucocorticoid. NCLEX will never do this. They're never going to tell you what the medication was. So they'll just say it's methylprednisone. All right, IV, that's all they'll say. Okay, well, pulmonary meds are all BS, right? Bronchodilators first, then steroids. Well, that's a steroid, so that's second. So get rid of that one. Give the client a SABA, right? So short acting. Okay, so you can say, well, this is okay. Well, I mean, it's like, okay, well, which one? Right? It's a little vague, right? So, but I'm not sure, so I'm going to keep it. So I keep. Next one, hang an IV infusion. All right, hold on. Status asthmaticus. All right, titrate this. Oh, drip rates. I don't go and test that stuff, but whatever. And then go from there. Okay, well, now IV infusion of bronchodilator. Okay, what am I going to do? A level from this person now, right? To make sure it's titrated at the right level. Is that solving the problem now or later? That's later. So get rid of that. Assess the client's breath sounds every 5 minutes. Okay, I'm not sure. All right, so keep that. All right. All right, so go back to the question. I'm not sure. I have 2 things left. I'm dismissing number 2 because I think it's vague, and I'm thinking, okay, is this teacher trying to trick me? That type of stuff, right? So client presents to the emergency department, ED, diagnosis, status asthmaticus. Do something now, okay? So status asthmaticus. Which intervention, in case I didn't know, do something first. All right, this is the best answer right here over this. So this would happen first. Would I need to assess the client's breath sounds before? Well, if they're presenting with status asthmaticus, they're diagnosed with, there they are. Right, so I need to give them what they need to have. And then
I thought that status asthmaticus was as like an asthma attack that wasn't responding to bronchodilators. Like I remember that from nursing too. So is like option number 2 just the best out of the options that were given?
Yeah, because what is number 4 doing, right? So, yeah. I mean, client's breath sounds every 5 minutes. Every 5 minutes. So you're going to sit on this person. If you had the opportunity to give them something, or sit on it for another 5 minutes, would you sit on it for another 5 minutes? This doesn't change the patient at all. Mm-hmm. This could potentially change that patient. And status asthmaticus just means that asthma that resulted in an admission to the ED. Okay, so at home, they're using their inhaler. It doesn't work. They have to come to the hospital. Status asthmaticus. It means that whatever they were doing at home isn't working now. Let's start to bring up the big guns and get them going. Nebulizer treatments, those type of things without albuterol, dual nebs, get them moving. So yeah, there is some truth to that, number 2, nursing 2, but what's going to change the patient here? All right, everybody doing all right?
Yep.
Yeah, it's better at the beginning of the day. All right, so next question. All right, so again, concept is still here, right? So the concept is always the same, right? So it's always BS, right? Bronchodilators before steroids. It's always albuterols first, rescue inhalers, that type of sense, right? So no matter what, that's why when we talked about it in class yesterday, and we were saying, we were saying that, when you're looking at the meds and stuff like that, you kind of breeze over them because it's kind of the same concept. It doesn't matter, as long as you can recognize that it's a longer acting, not a shorter acting, then you're pretty much good to go with that. So let's talk about it. So statement indicates the client understands, so looking for something correct, right? Regarding inhaled, okay, so steroid medication. Now, generally on an NCLEX, they would never have this. They would say just this, metered dose inhaler. And the reason they would do that is because of, it would catch the person that sees inhaler and thinks it's a bronchodilator and catches that person not recognizes the acute medication. These inhalers, you can have them as a albuterol, but you can also have them as a steroid inhaler, right? So, that's kind of how NCLEX would focus on it, because they're not going to give you as much information. The questions are going to be short, and they're just going to give you the med. And all right. So, anyways, I should take 2 puffs of the medication within 30 seconds of an out. Okay. Client understands the teaching regarding Okay, 2 puffs within 30 seconds. Okay, maybe I'm not sure on that. Okay, so I should eat before the inhaler to prevent an upset stomach. Maybe I'm not sure about that. I should rinse my mouth out before using the inhaler. That seems okay. Everybody knows about steroids and everything like that. I should not take these drugs when I'm having an asthma attack. Again, BS, acute, this is most correct. Even though I might have not have been sure about these, that's why you always keep it. Even if you're not sure about a question, don't start to panic. Put a question mark because this supersedes my questioning this stuff, right? Because it kind of gets, maybe I didn't study as much, or maybe I didn't know that about that medication, but I do know this, and everybody knows this, and this is the most acute thing for the patient, that they're grabbing this inhaler in an asthma attack. I think they're like, oh, get my inhaler, and then they grab the Flovent. It's not going to work for them, right? Steroids, and that's it. All right, good. Let's talk about it. So diagnosed. All right, so diagnosed again, you have airway disease, reactive, not COPD, ED. Right, you're in the ED again. All right, so that's important to know. In case you didn't know that was acute, they're having difficulty breathing. In case you didn't know it was a problem, they're also bluish tint around their mouth. Okay, so this is a acute question, period. All right, so what are you going to implement first on an acute patient that is blue around? It's not like they're taking amiodarone, right? So, I mean, this patient is hypoxic. Okay. All right. So let's go into draw blood for CVC. What? That doesn't make any sense, right? So get rid of that one. Apply oxygen via nasal cannula. Doesn't seem like a bad idea. I'm going to keep it. Okay. It doesn't mean I'm absolutely like, yeah, that's what it is. But I'm going to keep it. I'll move on. Request an ABG. I'm not sure about that because I have nothing other than this patient like this. So no, that doesn't change the patient. Okay. And then take the client's vital signs. Okay. That also doesn't seem like a bad deal. All right. So let's run the scenario. Here we have a patient that diagnosed bluish around their mouth. So there's definitely data there, right? Do I need vital signs? Okay. So here we go, right? So here's a patient, asthmaticus, or whatever's going on with them. They're bluish. And I'm like, okay, let me take your temperature. Right? I mean, now they're holding their breath while I'm taking their temperature because I have to do the temperature. Because everybody here knows vital signs are temperature, right? So everybody knows, oh, but what if they have this? Okay, well, all right, let's keep going. Pulse, right? Same thing, right? Would you sit on this patient when you have the opportunity to give them something, right? And so that's why that's the credited. So this is classic of like, well, I need vital signs, right? Well, do you need vital signs? With a patient who is having difficulty breathing and bluish tint around their mouth, be confident in what you're doing. Now, the only way you would dismiss it generally is, well, how much oxygen, right? Are they a COPD patient, right? You start to think about those things to dismiss that answer. This is the most correct. Is this actually could change? This right here is acute, period. And that's what the issue is. There's data in the question, do something, change that patient, and that's why that's the correct answer. All right, next one. All right, so which intervention should the nurse implement? So client and nurse discussing frequent asthma attacks. Okay, so they're having a lot of attacks, right? All right, so how frequent? Right, that's the first question. All right, so what does that mean? What's frequent to them is different than what's frequent to me or to you, or frequent doesn't really mean anything to me, right? All right, so which intervention should the nurse implement? All right, well, discuss the client moving to a different climate. What you should do, you should move to Florida. Right? Okay, oh, that's not okay, yeah, that's what I'll do, right? That doesn't make any sense, right? And where is a different climate? Like, where are they now? Got it? Are they in a dry climate? Where there's less asthma? Where's the patient? I don't know. That's like, are you playing with any pets? Right? Same sort of thing. Vague. Like, what's the patient? We don't have anything about the patient. Is it universal? Right? So we don't know any data on this patient, so you can't do that. That's also what's called more about the nurse versus the patient. You're saying, well, I know that in the city, the chicken house, all those type of things, and climate changes can cause asthma. So therefore, I'm going to discuss that patient should move, right? That's not about the patient. That's about the nurse making a decision on that patient. Okay, that's what's called about the nurse, not about the patient, all right? The next thing is ask the client when and where. Okay, that's about the patient. Hey, when do you have it? Well, I notice whenever my uncle comes over and is smoking crack in the living room, right? Next thing you know, I have an asthma. Just so you know who's paying attention out there, right? So, or, I'm over at Josephine's house and the chickens come in and, all these type of things and they have these, so, I mean, that's important data to know, right? When these things attack and, when it happens. So I'd want to know all that data, okay? So then we say, okay, tell the client to buy cotton linen. Oh, great. Now you're giving them a shopping list, right? So, first of all, what's their economic status? Why cotton, right? Does cotton have more dingleberries on it than, than satin, right? Does it have more phrase? Does it have more potential for increasing asthma attack? I don't know, right? So don't give them a list. Don't give them a shopping list of what they need to buy. That's the same thing a patient presents with anorexia. Not like anorexia, like anorexia or anorexia diagnosis, but more like anorexia because of the digoxin toxicity. Okay, and then you're like, well, let's make a list of your favorite foods. Well, the patient is depressed and doesn't want to eat. And you're like, well, seeing that you're depressed, why not write a list of all the foods that you like or that you used to like, and let's bring them in. No, they're depressed. They don't want to eat the things they normally like. So therefore, don't give the patient homework. Don't purchase things for them because it's not solving the problem. All right. Teach the client to attempt to avoid all stress. Great. Then that's measurable. No, it's not. Get rid of that. So this is more about the client. This is all about diagnosing and treating, basically. Right? Where this is strictly about what's going on when these attacks occur. And that's what's called about the patient. Yeah, that's a hard thing for new nurses to think about. Is that about the nurse or is that about the patient? And that's always the thing. Do I get the data? Am I getting data from the patient? So if you were to run this like an A and I, right? So discuss client moving, that's an implementation. Ask the clients, that's an A. Tell the client I. Teach the client I. A is the priority one, assessment. All right, next thing. Okay. All right. So let's talk about it. Charge nurse on a medical unit making rounds. Okay. So patient, 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 patient. Okay. Which client should the charge nurse see first? Okay. So CV cap. All right. Client diagnosed with reactive. Right, that's different. That's like asthma, bronchitis, airway disease, pulse ox. Is that a stable patient or unstable patient? Unstable. Keep it. Diagnosed with heart failure, has 2+ edema, low. Stable or unstable?
Stable.
Stable. Client diagnosed with type 2, whose blood glucose reading is 243. Stable or unstable?
Expected.
Stable.
Stable. Yeah. I mean, if you were like, I'm not sure, keep it unexpected.
I mean, I feel like if it said like type 1 diabetes, it'd be different, but type 2 is like.
Yeah, you're not too worried about it. Just stop eating, Twinkies, right? So,
Yeah.
So, but if you were like you missed that class and you're like, okay, unexpected, that's nothing wrong with that. All right, so diagnosed with COPD, okay, who states, right? So he cannot breathe without oxygen.
Expected.
Expected.
Okay, well, maybe like it's unexpected. I don't know, so keep it. All right, so the next thing is this expected or unexpected? Diagnosed with reactive disease whose pulse ox is not expected or unexpected? Unexpected.
Unexpected.
Yeah. Okay, so keep that. Then we move down. Client diagnosed with type 2, whose blood glucose reading, that's expected. So we get rid of that.
Mm-hmm.
Client diagnosed with COPD, he states he can't breathe without his oxygen. Okay, well, I mean, maybe it's a conversation, right? I mean, he's stating he can't breathe without his oxygen. Okay, so I'm not concerned about that because patient's stating. Okay, so now we start to get into, so they're both airways, right? Okay, so then we're going to say into this one right here.
Well, if he's stating he can breathe.
Yeah, we're going to keep it, right? So we're going to keep on running. This is both airway. We're going to go to the A right here. So acute, chronic, these are both acute. Everybody's good with that? They're all acute? Because if you're like, I'm not sure on this, I'm going to keep it. So we get to the last P, and that's what? Actual and potential. Okay. Is this an actual problem? Yes. Is this a potential problem? Potential. That makes that the credit answer. Yeah, I mean, yeah, that's why it kind of does work when you start to look at it. You just keep on just running through it. And if you're really not sure, just keep it. It will cancel out because the questions are written in a way that they're supposed to cancel out, right? But you have to do process when you're getting it. Yeah. All right. Next up. And I would say that in actuality, in this question, he's just saying, hey, I can't breathe without my oxygen. He has it on. It might be just a conversation for all I know. But this is actual data right here, right? I mean, it's what it is. And remember, you're going around doing your rounds, right? Yeah, priority, right? So 89-year-old, assessing an 89-year-old diagnosed with pneumonia. Which signs and symptoms expect? Most likely a pink fluffy sputum. I'm not sure about that. Yes, I'm sure about that. High fever, chills. Yes, I'm sure about that. No. Okay. So now I'm down to 3. And I think, okay, well, we have an 89-year-old pneumonia diagnosed. Expect now they tend to show this first, right? So this is probably 1/2. And not all patients will have chills, right? I mean, but this is actually, I think that this question right here, I wouldn't consider it a solid question because I think there's some problems with this right here. These two answers, the two, I know what they're going for on a question like this, but I don't think it's 100%. Like as far as this is what it is, I think you need more data up here for it. And this is why, like I said, people are writing questions and stuff like that. They're not always 100%. You know. Next one. This is the last one. The heaters. Yeah. All right, so let's peg two.
I thought each was vague.
What's that?
I thought when it said each shift, that was vague.
Yeah, it is vague. Yeah, and that's kind of what we're talking about as far as, you know, I mean, like I said, if I'm just pulling a batch of questions and he's pulling them into this, right? So, you know, they're here for a certain reason. Like I said, like the previous one, I don't think that previous one was a solid question. This is also not a solid question. So just understand that as you're doing these questions, they're just not perfect, right? And now the problem is that, you know, you get questions like this, even on tests, they're not perfect, right? So they might just like, oh, here's a question, or seems good. And they understand because they have that content, but it's not written correctly. And so if you're trying to learn a process, you can get lost in a question like this because it's not written correct. So I know what it's going for, and the risk is because of PEG tube feedings, right? PEG tube feedings is the location of the PEG tube with the lungs and the aspiration of it. That's kind of what the thing is, because you can assume that the motility is, and the digestion is the same as normal peristalsis. So inspect the insertion line at the what? Okay. Elevate the head of bed after feeding. Okay. Also take lungs each shift, and that's where and as needed, and then change the tube feedings every 72 hours. That's incorrect. As far as most, if I was to approach this is kind of like an old school, I would be approaching this on the ABCs, right? Okay, which one's airway? And then this is the airway. This is going to kill the patient most likely because I get the concept. The concept is probably aspiration and regurgitation, reflux. That stuff is going to cause pneumonia. And I think that's what it's going for on a question like this. So the concept of the question is PEG tube to pneumonia. And then you say, okay, well, that's the concept. So what does it ask? Expect this. Does this do it? Well, I could assess this. And then, what is it asking? Including the plan of care. You know, so this is a process where I don't know the policy for this. You know, this doesn't make any sense. And, you know, the patient it's in the PEG tube, so it's not necessarily for that. So this is kind of the most correct. You might, like I said, dismissed it because of this each shift and as needed. You know, they're writing out a care plan, right? So it's not like the individual is taking care of this patient. It's like you're writing out a care plan, and that care plan might be, even if you're doing a 4-hour shift, right? If you're coming in as a 4-hour shift, you would also take the lunch hours, right? If you're coming in for an 8-hour shift, you would also take the lunch hours. Got it? So I don't think shift is really necessary to know, where on the other ones, the frequency of it is more important. Okay. So yeah, now I'm re-looking at, I get it. I get why it's unnecessary as far as what it is. All right, that's about it.